So talking about the fractures now, very commonly nowadays they'll show you an image and ask you to identify. Jefferson fracture is a fracture of the atlas. Mnemonic is chart. So Jefferson atlas. Fracture of C1, vertical injury, burst fracture of the ring. Whereas hangman fracture is C2 over C3 spondylolisthesis. If you have to choose one, C2, remembered by the mnemonic H2. Nightstick fracture is a fracture of the shaft of ulna. Isolated fracture of shaft of ulna due to a direct blow of the nightstick on a thief's forearm by a policeman. Schoffer's fracture, it's an intra-articular fracture involving the radial styloid. Very common image, very commonly asked. Colles fracture, extra-articular fracture, first metacarpal is anterior with a posterior displacement. Posterior is Colles. Bucket handle fracture, you're looking at the pelvis fractures. Bucket handle fracture means that is a fracture of the posterior element of the pelvis on one side and the anterior on the opposite side. So it's a type B of the pelvis injury. So anterior, posterior, opposite side. Whereas when the posterior elements provide as a hinge and the anterior elements open on it, it's an open book injury. Again a type B. Open book has a B. So there is instability occurring, hinging on the posterior element, the anterior elements open up, or a bucket handle where one side posterior elements of the pelvis and the opposite side anterior elements of the pelvis are damaged. So open book and bucket handle fractures are type B pelvic injuries. Whereas Malgagny fracture, there is involvement of posterior anterior elements of the pelvis on the same side. Straddle fracture is bilateral superior and inferior pubic rami. Pylon fracture, again an intra-articular fracture, comminuted fracture involving the lower end of tibia. Aviator's fracture is a vertical fracture due to the force involving the body of talus. Jones fracture and pseudo-Jones fracture. Jones fracture is fracture of the base of the fifth metatarsal. Pseudo-Jones is more proximal avulsion fracture. Remember, pseudo-Jones is more proximal, occurring at the tip of the metatarsal. Jones at the metaphysio-diaphyseal junction. Proximal humerus fractures have greater tuberosity, lesser tuberosity, head and the shaft as 4 parts. So you have greater tuberosity, lesser tuberosity, head and the shaft, 4 parts classified by Neer's classification. Then you have supracondylar fracture humerus, extension type, posterior displacement. Then you have Monteggia fractures, fracture of ulna with the dislocated radial head. Type 1 is the most common, where it goes anteriorly, the radial head. Galeazzi fracture, fracture of radius with damage to the distal radial ulnar joint. Boxer's fracture, fracture of the neck of the fifth metacarpal. Bumper fracture, involvement of the lateral tibial plateau, hitting by a bumper on the tibia. Cotton's fracture, there are 3 malleoli around the ankle. The medial malleus, the lower end of tibia medially forming a joint. The lateral malleus, lower end of fibula forming the joint. Posterior malleus, again forming joint. When all the 3 malleoli are damaged, it's called as a trimalleolar fracture. And the mnemonic is CT. Cotton's is a trimalleolar fracture. When only the medial and the lateral malleus is involved, it's called as a Pott's fracture. It's a bimalleolar fracture. Malleolar fractures are being loved by the examiner. Chopard's is an intertarsal injury. Remember, Lisfranc's is a tarso-metatarsal injury. Chopard's and Lisfranc's are anatomical terms. Chopard's amputation is intertarsal amputation. Lisfranc's amputation is tarso-metatarsal amputation. Chopard's is an intertarsal area. Lisfranc's is the tarso-metatarsal area. And then the classical thing, March fracture. It involves the neck of second metatarsal more than the third. Some books have confused the shaft. Remember, it's the neck. Ankle injuries are tough areas. Even postgraduates of orthopedics will find it difficult. But there are some things that you must remember. Classification is log Hansen. First question. The first word in an ankle injury is the position of the foot. Supination means the sole looks medially upwards. Pronation means the sole looks outwards. So first word is the position of the foot. Second is the force on it. Supination with externalization means the most common ankle injury. The second question. In supination, externalization, there will be an oblique fracture of the medial malleus and there will be fracture involving the medial malleus, which is more of horizontal. Whereas supination, the force along with adduction force will have a vertical fracture of medial malleus and a horizontal fracture of lateral malleus. This is the third question. In adduction injuries, there is a vertical fracture of medial malleus. Then comes pronation abduction. There is a comminuted lateral malleus fracture with horizontal medial malleus fracture. And then you have pronation externalization, where you again have oblique fracture of the lateral malleus. You need to remember three things. Log Hansen classification is for ankle injuries. Supination externalization is the most common ankle injury. In supination adduction injuries, there is a vertical fracture of medial malleus. These are three things that you must remember. Runner's fracture involves the lower end of fibula. Classifications. Classifications of fractures are very commonly asked. I will tell you the important ones. Needs for proximal humerus, Gartland for supracondylar humerus, Beddoes for Monteggia, Dennis 3-column theory for spine, again very important, Juden and Letourneau for acetabulum, Thompson and Epstein for the posterior dislocation of hip, Pipkins for the head of femur, Gardens, Powers and Atmical for neck of femur, Winkist and Hansen for shaft femur, more important than you can imagine, Guslow Anderson for the open fractures. These are the important injuries and classification that you must know. But before the exam, try to go through all of them. Needs for proximal humerus, the four parts, the head of humerus, the shaft of humerus, the greater tuberosity and the lesser tuberosity, which I had told you. And then is 3-column theory, divides the vertebra into three parts. The anterior part is anterior column, the middle part, the posterior part of the vertebra is the middle column, and then the pedicle, raminus, planus, process, the posterior column. If 2 out of 3 columns are involved in the unstable injury, when you have to treat a fracture, remember some rules. Extra-articular fractures are close reduced. Intra-articular fractures open reduced. To prevent the arthritis, small bone fractures are treated with screws and K-wires. Children will obviously have small bones, so either you don't operate them, so conservatively manage them, or put K-wires. Well, you put K-wires in children when it's an injury near the joint. K-wires, also called as Kirschner wires, are stainless steel wires. Tractions are conservative methods. As the medical science is evolving, the art of using splints and tractions are being lost. But you should remember, you have a skin traction where you will pad the area, apply the splint or the traction on it, and apply a weight of 3 to 4 kgs. Skeletal traction means the Steinman pin or the K-wires or any metallic thing will go inside the bone and then apply a traction where a weight up to 10% of body weight, but some books do mention 20 kgs can go. In skin traction, 3 to 4 kgs can go. Then when you are fixing a bone, there's a principle called as tension band principle. Every bone has a convex surface called as a tension surface and a concave surface called as a compression surface. Whenever there is a fracture, since the muscle pull is more on the tension surface, it will open up on the tension surface. So what you do, you apply a wire or a plate on the tension surface so that the distraction which is occurring there, it's going away. that distractive force is converted into compressive force. इसे हिंदी में कहते हैं दूरियों को नजदीकियों में कन्वर्ट करना, to reduce tension. So the wire or the plate is applied on the tension surface, the convex surface, to convert the distractive forces into compressive forces, called as tension band principle. Tension band wiring is done for fractures of patella, fractures of olecranon and medial malleus. Very commonly asked MCQ. And then comes external fixator. I told you open injuries, they bright and external fixator outside the skin. So you have the Steinman pins, which will be going to the bone for skeletal traction. You have Schanz screws of different diameters which hold the bone, do not cause through and through. This is for external fixator. You have a universal clamp which will hold the Schanz screws. Then you have the rods. And that's how the external fixator is applied. Then when you go for the plating system, the primary healing method, it has evolved over time. The classical plating was expose the fracture, fix them like a jigsaw puzzle. There was a dynamic compression plate. Why dynamic? Because the screws were applied so that the fracture site, while applying the screw, will compress against each other. Then there will not be any movement. Primary healing will occur. No callus formation. This is dynamic compression plate. The problem, it was denuding the entire bone surface of the blood supply. So they came out with the grooves underneath the plate called as limited contact dynamic compression plate. This became overnight success. But the problem was, even in this plate, the screws, if the bone was taking more time to unite, will back out. So they came out with a method in which there were threads on the screw head, and in the holes there were threads. So these threads will lock to the plate screw. And now the screw can't come out. The plate has to come out, which is practically not possible. These were called as locking plates. They were for weaker bones, weaker area on the bone called as metaphysis, around the periprosthetic fractures, because there is minimal space, less screws can come. You need a stronger construct. Locking plate, very strong, or non-union, where prolonged fixation is required. These were the classical dynamic compression plates. You were applying the screws and applying the compression at the fracture site. Then the grooved, limited contact dynamic compression plate became successful, but the screws can come out. The screws can be cortical screws, where the cortical bone or the threads can be a distant or partially threaded cancellous screw for the cancellous bone. But both the plates, if prolonged fixation required, the screw can back out and the plate will fail. So then came the locking plates, locking screws, and the holes, combi holes, where a normal screw can go or a locking screw can go. So these were the locking screws. And then these are different types of screw. The cortical screws for the cortical bones, the cancellous screws for the cancellous bone, and the locking screw for the locking plates. Some of the instruments used in orthopedics. You can use an osteotome to freshen out the bone margins or to make a cut. You can use a curette to scoop out the contents or take out the cancellous bone grafting. You can take a bone cutter to take out a good cut of the bone grafts or cut anywhere. You can do a nibbler, again to freshen out, make a raw surface. Bone nibbler is one of the commonest instrument used and common instrument asked as an image. You can have a bone clamp, bone holding clamp. Whatever has a teeth like a dog will hold a bone. So there are tooth, bone holding forceps. They can look anyway. Wherever is the tooth, that's for holding the bones. Tooth, bone holding forceps. Tooth, bone holding forceps. So these are the bone holding forceps. This area will hold the bone. This is a smooth surface. So this is bone and a plate holding forceps. Why would you have a bone plate holding forceps? So that the smooth surface will hold a plate and not corrode the metal. Both the images have been asked. Bone clamps, that's the bone holding forceps, and the bone plate holding forceps in the exams. They've also asked bone nibblers. Nailing, I told you, is an intramedullary implant. Secondary healing is there. Callus will be formed. You lock it with the screws to the bone so the malrotations don't occur. External fixators for open injuries. This is classical external fixator. More rigid rail fixators which came in AIMS November 2019, or Elizarov fixator, which is used to increase the length of the limb. Its working principle, there is distraction histiogenesis. How will you do that? You will make a cut at different bony ends, wait for the callus to form, because this bone cut is like a fracture, and then gradually distract it and the bone will be formed. This is the principle of Elizarov. Let's imagine. This is atrophic non-union. The bony ends are avascular. This can never unite. Why? Because the fibula is intact. Will not allow the fracture ends to come together. Also, it's atrophic. What will you do? You will make a cut. You will make a cut. Freshen the margin. You have also cut the fibula so that they can come together. Original length of the limb. Now you have got them together, but there's a length loss. One more observation. There is a cut in the metaphyseal area. This is epiphysis. This is the physis, the metaphysis. Metaphysis. Here you have made and corticotomy, means cut the cortex. Only the cortex, not the entire content. Now get an X-ray after 3 weeks. After 3 weeks, if you see callus, increase the distance between these two rings gradually at the rate of 1 mm per day. What is that rate? That's the rate at which tissues heal, nerves recover. And get a compression between the area where there was a fracture. You also put a bone graft, because atrophic non-union, you stabilize, you freshen the margins, and you put a bone graft. Try to put a compression on the rings here between ring 1 and 2, and distraction means open up between ring 2 and 3, and that's how you follow it with the X-ray. This is called as distraction osteogenesis. You are actually lengthening all the tissues, so distraction histiogenesis at the rate of 1 millimeter per day. Some common errors in the books. Rolando is not extraarticular, it's intraarticular. Lisfranc, some people have mentioned intertarsal is tarsometatarsal. Most common bone to fracture at birth is clavicle. Thurston Holland is Salter Harris type 2, not type 2, but type 4. Supracondylar fracture humerus. The most common nerve involved is not radial, it's anterior introitious nerve. We will talk in pediatric orthopedics. CTV cast is always above knee. Fracture healing, hematoma, granulation tissue, callus, then consolidation, then remodeling. Last 2 stages. In nerve injuries, IGAVA, the spelling is I, not E. Remember that.